All right. Good morning, everyone. My name is Manjot Gill, and I'd like to welcome you all to Chicago. We'll be beginning Session 5, Medical Retina and Chorioretinal Vascular Disease, Part 1. And we'll start with a talk from Audina Berrocal on atypical retinopathy of prematurity.
Great, thank you, and thank you to the organizing committee for allowing me to speak to you today. These are my disclosures. So atypical ROP is a newly recognized, genetically based, clinically focused category of diseases, most commonly seen in early childhood. Now it's been recognized in adults with atypical vascular disease, and familial exudative vitreoretinopathy fever is the most common typical presentation. Telomere biology disorders are a newly recognized class of disease within this varied phenotype, and phenotypic variations often lead to misdiagnosis, misclassification, so genetic testing is evolving as the mainstay of diagnostic accuracy. So what is classic ROP? Classic ROP, we have a homogeneous ridge. It's a symmetrical disease, predictable progression and regression, low gestational birth and age, oxygen exposure, and the vascular changes are popcorn. You can have a vascular retina and the focal hemorrhages. So classic ROP, you see the homogeneous ridge, the avascular retina, homogeneous ridge with popcorn lesions. And what really is atypical ROP? So atypical ROP is asymmetrical, non-homogeneous ridge with sprouts anterior to the end of the ridge. You get exudation, you get persistent atypical vascularity with observation, and you have an atypical distribution of retinal ischemia, many times posterior to the ridge. So this is asymmetric disease. This is a case of retinal ischemia posterior to the end of the vasculature. You get these sprouts of vascularization anterior to the ridge. You can get this atypical vascularity with the avascular retina too, and you can get a lot of exudation and posterior ischemia as you see in this case. So what is important in these cases? To do ultrafield angiography, targeted OCT, and definitely genetic studies. So a few cases to show you. This is an infant born at 31 weeks with persistent asymmetric disease and exudation, and genetic studies showed Roper with a mutation of the Frizzle4 gene. This is an infant born at 34 weeks, asymmetric and persistent disease, Roper case with an LRP5 mutation. And now the more interesting cases to me are this infant born at 24 weeks with asymmetric disease, hemorrhages, posterior ischemia, very atypical, and responded very atypically to treatment. And this was a case of prematurity and a telomere disease with a mutation in the CTC1 gene. An infant born at 36 weeks, asymmetric disease, atypical vascular pattern, persistent disease, and this is again prematurity with a telomere mutation in the RTL1 gene. So familial exudative vitreoretinopathy, we get asymmetric disease, atypical ridge with sprouts anterior to the ridge, and we can actually do genetics, and these are the most common 4 mutations as of today that we see in fever. So Roper is fever, but in the presence of prematurity. And now we have TBD diseases, telomere biology disorder, asymmetric disease, posterior ischemia, atypical vascular arborization, exudation, and you should do angiography, but the key is that the genetics have to be targeted. It's just not just a simple panel. So I propose that telomere biology disorder in the presence of prematurity, we can call them ROP-MER. And in conclusion, high suspicion for atypical vascular disease in infancy, fever, Roper, and TVDs have significant heterogenic phenotypes. Atypical cases of ROP mandate high suspicion and deserve wide field imaging and also targeted genetics. And it's important for the family, for family screening, planning, and for long-term outcomes. Thank you very much.
Thank you, Audina. All right, next up we have Mark Johnson, who will be talking to us on pathogenic mechanisms of immune checkpoint inhibitor-associated retinal and choroidal adverse reactions.
Thank you, Manjo. I'd like to start by acknowledging my co-authors, and in particular, Rachna Hallier, who's our superstar fellow who really did all the work here. None of us have financial interest in this topic. By way of a disclaimer, as a non-immunologist, I'm a little out of my comfort zone here, so I've tried to dumb this down for simple retina specialists like me. As we know, immune checkpoint inhibitors are monoclonal antibodies that stimulate endogenous T cells to target cancer cells and have revolutionized the landscape of cancer therapy. The most commonly used ICIs act by targeting inhibitors of T cell activation, especially CTLA-4, PD-1, and PD-L1. Fortunately, ocular ICI-related adverse events are relatively uncommon, occurring in 1 to 3% of patients. Posterior segment inflammation accounts for about 5 to 20% of cases and is more likely to be visually significant. So the purpose of this was to better understand the adverse reactions of ICIs involving the retina and choroid by summarizing and categorizing the postulated mechanisms of ICI-mediated retinal and choroidal inflammation. So we reviewed selected literature describing immune-mediated retinal and choroidal adverse reactions associated with ICI therapy. We then drew parallels with ICI-associated findings in other organ systems, as well as mechanisms underlying known ocular inflammatory disorders, and then synthesized and categorized the likely pathogenic mechanisms underlying the adverse reactions in the chorioretinal layer. In general, we found that ICI-induced posterior segment adverse reactions can be categorized into 3 major mechanisms of unintended targeted inflammation. That identification of the involved mechanism can be guided by baseline multimodal imaging and thorough medical history, and that more than one mechanism may be involved in a given patient. So let's look at each of these categories that we're proposing. Type 1A involves T cell activation and then cross-reactivity of anti-tumor T cells with ocular tissues. This is the one that is the most intuitive, was nicely illustrated by Matt Cunningham's beautiful case of an ICI-induced VKH-like reaction. So in this one, there's cross-reactivity of anti-tumor T cells with melanin-containing cells in the uveal tissues. 70 to 80% of these reactions occur in patients with melanoma and account for 5 to 14% of all ICI-related ocular adverse events in melanoma patients. Like VKH, the reaction is associated with HLA-DR14, but it's less likely than regular VKH to have racial predilection, neurologic, auditory, and cutaneous involvement, as well as progressive fundus depigmentation and choroidal thinning. This is another example, in addition to Matt's case, showing pembrolizumab-associated VKH-like syndrome that was published by Chris Conradi and Associates a few years ago. Type 1B involves T cell activation with expansion of eye-specific T cells in predisposed patients. So the idea here is that in patients with genetic predisposition to chorioretinal autoimmunity, ICI therapy overcomes mechanisms of self-tolerance, leading to an augmented autoinflammatory response triggered by exogenous antigens. So these are syndromes that we're kind of familiar with. Various presentations have been reported, and they often mimic known uveitis syndromes like birdshot, MUDES, multifocal placoid chorioretinitis, and granulomatous uveitis. This was a case of severe multifocal placoid chorioretinitis associated with ipilimumab and nivolumab therapy that we published last year, sort of an extreme AMPI or amphigenous type case. In type 2 reactions, there is inflammation unleashed by ICI that causes retinal vasculitis with or without vascular occlusion. So ICI therapy can induce nonspecific bystander vascular inflammation via perivascular lymphocytic invasion, vascular epithelioid cell infiltration, and high levels of cytokine production. And this can then lead to retinal arterial and venous occlusions with potentially severe vision loss from retinal ischemia or neovascular complications. ICI therapy has also been associated with primary CNS vasculitis and with systemic large vessel vasculitis like giant cell arteritis that can, of course, affect the eye. This is an example of anti-PD-L1 associated retinopathy reported recently by Inez Lanes that involves AMN-like lesions indicating vascular occlusion along with obvious retinal vasculitis. And finally, type 3. In type 3 reactions, there is autoantibody-mediated inflammation. ICIs can elevate or can activate humoral immunity by various mechanisms, which I list here, all of which may lead to B-cell clonality and expansion and autoantibody production. So, as one might expect, the diseases driven by ICI-induced retinal autoantibodies are those that we might anticipate. They can look like autoimmune retinopathy, cancer-associated retinopathy, and melanoma-associated retinopathy. And this is the case that we're treating now of severe pembrolizumab-exacerbated CAR in a patient with bladder cancer whose vision is LP in both eyes. So this can be quite devastating. In just a brief word about management, patients with ICI-associated posterior segment inflammation require careful management by uveitis or retina specialists in conjunction with the oncologist. Treatment might include topical, local, or systemic anti-inflammatory therapy. Decisions about cessation, continuation, and resumption of ICI therapy should be made on a case-by-case basis depending on the severity of the ocular disease and the severity of the underlying malignant process. Most cases of ICI-associated inflammation in the eye have favorable outcomes and may even be managed without cessation of ICIs, but some syndromes may lead to permanent vision loss. Ocular inflammation can persist after discontinuation of ICI therapy, and if therapy is restarted, close surveillance is warranted. So in summary, three major categories of inadvertent T-cell mediated inflammation underlie the ICI-associated chorioretinopathies. Identification of these mechanisms can help direct the diagnostic workup. Optimal management requires collaboration with the oncologist. Generally, the visual prognosis is favorable if treated appropriately, but some reactions can result in severe and permanent vision loss. Thank you very much.
Thanks, Mark. That was a great overview for a non-immunologist. I should just mention there's been a slight change to the schedule. Unfortunately, Peter Campachero could not be here with us, so the session has been slightly abbreviated. So our next talk is from Robin Vora, Time is Vision, a comprehensive strategy to shorten the time to central retinal artery occlusion diagnosis and management.
Good morning, everybody. My name is Dr. Robin Vora, and today I want to share my slides first and then our initial efforts to shorten the diagnosis of CRAO. And
no, can we get Dr. Vora's talk, please?
And reset my time too. Okay. So I want to share with you our efforts to accelerate the diagnosis and treatment of CRAO and share some initial results. Of note, I'm a consultant for Kyoto Drug and Development that has a molecule for CRAO, and off-label use of thrombolytics will be discussed. Let's start with one of my very sweet...
Oh, geez. Can we bring Dr. Vora's slides up, please?
All right, let's start. Oh, gosh. All right, let's start with one of my dear patients. I take care of for AMD. She approved the use of this photo and story. And about 6 months ago, I came into the office, and my Epic inbox had this email. You know, Dr. Vora, I thought you'd be interested to know that my left eye suddenly went dark halfway down. I called 911, came to Kaiser, and they diagnosed me with a CRAO. Yada yada, they gave me a clot-busting drug, and gradually I got my vision back, yada yada. And I read this email, I'm like, wait, what? So I went back to the chart, and sure enough, at 1:30 she lost her vision in the left eye. She got to the ER around 2:55. She had fundus photos in the ER at 3:32. This is her baseline photo. Remember, I take care of her for AMD. This is her in the emergency room, and sure enough, there's a Holland-Horst plaque right there with some retinal whitening. Our telestroke team was consulted at 5:04. She had a CAT scan that was resulted at 5:29, and under full consent, with compassionate use in mind, she got tenecteplase IV thrombolysis at 5:30. So the question for the audience is why and how do we get to this point at KP Northern California? And first thing we all know, CRAO is probably a top 5 bad disease in retina, right? Without any treatment. However, if you really study the literature carefully, there may be some signal for those patients who you can treat within 4.5 hours with thrombolysis. And this is a recent meta-analysis. 74% of patients treated within 4.5 hours improved by 0.3 logmar, and about 39% got better than 2100. So maybe there's something there, right? But to get there, you have to speed the patient time to diagnosis. We've done a lot of efforts in our systems to get there. You have to tell the call center, tell your nurses, tell the emergency room, tell your optometrist. Monocular vision loss can be a sign of stroke. But it doesn't really matter if the patients get there early if you can't get them diagnosed early. So we've gone ahead and deployed fundus cameras to all of our emergency rooms. Here are some pictures from the field. This has been a huge hit for our ER docs. They can finally see what we see. They call it the EKG of the eye, and it's indispensable. If you're looking to convince your community hospitals to invest in this technology, this slide may help. We found that for patients who come in with blurred vision, visual disturbance, loss of vision, these cameras decrease the length of stay by about 10%. If you calculate the amount of money that it costs to be in the ER plus ER crowding, this technology probably pays for itself to a certain degree. So let me share our experience. These are just maybe the last 15 photos that have come through. As my partner, Dr. Gilbert, says, these photos were not cherry-picked. These were pure from the field. I want to share my limitations before we share the results. This is a non-randomized study. Even though we taught the ER how to check visions, and it's not that hard to say hand motions or count fingers, this is not a clinical trial ETDRS measurement of vision. And generalizability, I work in a very integrated healthcare system where there's great balance between telestroke, ER, ophthalmology. Your mileage may vary in your community. So bottom line, this was not a clinical trial. However, we do have a lot of experience to share. For 2021 and 2023, we had 295 cases who presented within a month. 85 of those cases came in within 4.5 hours. Because the cameras rolled out sequentially, because there are certain patients who are not candidates for thrombolysis, 50 of them did not get treatment and 35 did. As you can see, the groups are relatively comparable, whether age, gender, race, or comorbidities. This is the key slide. If you're not paying attention, it's time to pay attention, okay? The visual acuities, left, logmar, middle, Snellen. As you go down, vision is better. This is the no treatment arms. The thickness of the bar is the number of patients in that cohort. Green means they're getting better, red means they're getting worse. You can see there's a big gray bar at hand motions and count fingers. Those are patients who started bad and stayed bad. There's a fair amount of patients who started bad and got worse. But there are some kind of more impressive improvements just with natural history. This is our treatment group. Just a general gestalt. There's more green than red, so it seems like patients are getting better. But however, remember, there's still a big gray bar there, patients who start bad and stay bad. There's also a bunch of patients who get better, and it's probably meaningful to go from LP to 2400, but it's kind of like terrible vision to still kind of bad vision. But there are some patients who did quite well. We can look at that in kind of more a tabular fashion here. If you compare the two groups, it's more statistically significant to do better if you get this tenecteplase within 4.5 hours, whether you're looking at worsening of 0.3, improving of 0.3, and it's numerically superior but not statistically significant to get better than 2200. If we just pull out the patients who are count fingers or worse, the thing that shakes out are you're more likely to improve by 0.3 logmar if you get the treatment. It's very clear to I think all of us who are attacking this work that time to treatment is very important, both for cerebrovascular stroke and for CRAO. This kind of proves the same thing. The likelihood of improving to 2100 or better is more likely if you get treated within 2 hours of symptom onset versus almost 3 hours of symptom onset. This is not a treatment that has no risk. These are 2 of our patients who developed intracerebral hemorrhages after TNK. Interestingly, actually, they're 2 of the patients who had 2 of the best visual improvements from hand motions to 20/80 and from LP to 20/30. The patient on the right had some imbalance that fortunately resolved within 2 months of treatment. The patient B was left with a permanent superior quadrantopia. And I guess you'll have to assess whether you'd rather be LP or 20/30 with a field cut. So in the future, I think all of us are anxiously awaiting the results from the European randomized controlled trials. These are not easy trials to do or to enroll. So I think it's been a long time coming, but rumor has it maybe end of this year, early next year. And I'm a very proud primary investigator of KUS-121, a molecule, a very kind of novel neuroprotectant, to also try to help these patients who have really devastating disease. Thank you to my research team, and thank you for the organizers for inviting me to talk.
Great, thank you. Thanks, Robin. All right, and last but not least, we have Not All Inflammation is the Same, What Not to Miss by Lisa Faia.
Good morning. I know you guys are all hungry, so I will keep it moving for you. Here are my financial disclosures. And so, we talk about what not to miss. And when I show you these pictures, you're like, duh, I know what those look like. We have endogenous endophthalmitis, CMV, we have lymphoma, we have HORV, we have toxoplasmosis, we have ARN. This is so easy. But when we're in clinic and we have our 60 to 90 patients that we're going through, and they just keep adding on patient after patient, sometimes these things aren't so obvious. And so where do we start? And so yes, sometimes we actually have to talk to the patient, and we figure out, infectious versus non-infectious, acute versus chronic. As we know, more acute issues tend to be more of the infectious orders or etiologies. Unilateral versus bilateral. We know, again, infectious etiologies usually tend to be more unilateral, but syphilis is also there, but it's bilateral. And location, whether it's retinal, choroidal, or choroidal, also is very helpful for diagnosis. And again, we got to talk to the patient. Where have they been? What do they do for a living? Are you a prison guard? Have you just recently come for a TB endemic area? Associated signs and symptoms, and what previous treatments they've had. So again, endogenous endophthalmitis. I do a lot of, well, not a lot, but I do some expert witness and treating physicians. And this heads a list of OMIC claims for delaying care. And it's a big deal because patients lose vision. And if a doctor has to go through a lawsuit, that can be very devastating as well. And so when we see the usual suspects here, the hypopia and the pain, well, of course we know exactly what it is. But please remember that 26% present without pain, 14% present without hypopion. So if you dilate these eyes, or when you dilate these eyes, and if you see retinal hemorrhages, think endophthalmitis until proven otherwise. And some of the less obvious, I love when my colleagues call me about blebitis. I don't know where this term blebitis came from. To me, it's bleb-associated endophthalmitis. And the big thing is the pain out of proportion to what we see from the examination. Endogenous, this can be a little bit harder. And what makes me think about this is when I was a resident at Mayo, I had someone sent in as preseptal cellulitis. I pulled up the lid, I can see the hypopion. Turns out his A1C was a lovely 13.2%. And so, of course, he was admitted. Obviously, blood cultures were positive, and unfortunately, he was dead within a week. So these are the kind of things where, yes, it's annoying, and hopefully you have staff, but if you see something like this and you're just not sure, send them to the ER, have them get the blood and urine cultures. It's not the same as when you do them in the outpatient labs. So occlusive vasculitis, we're just going to stick to the local drug therapies. We all know very well HORV with intracameral vancomycin, and it was a big deal, and obviously the committees that worked on this were very, very helpful. We have a case here that we had that came to us and basically had no hypopion, plasmoid aqueous, and you can see the inter-op photo here, the extensive hemorrhages, the extensive vasculitis, and that bottom panel, yes, that's the FA, and no, we did not forget to inject the dye. Unfortunately, this patient developed anterior ischemic syndrome, and the eye had to be enucleated. And in the lower panel, what you'll see is actually the vessel wall was not inflamed, but within it, you see the clots. So it's almost like a hypercoagulable state within the eye. Big topics now about the recent anti-VEGF and recent anti-GA drugs. As you can see here, Beauvue, 26 eyes had occlusive vasculitis, and you can see majority within 1 and 2 injections, but even afterwards, 16% were after the 3rd injection. Again, for Syfovre, the same thing. We see that there were some eyes there. Most of them that we know about are the ones that, again, were after the 1st injection. So we know if people had that, unlikely to, but you see the percentages here. And lastly, with Vabysmo, the same thing. As of August of 2023, 0.06 per 10,000 injections. So what do? I wish I had the answer for you. I wish I had the silver bullet. Because the biggest thing you could do is make sure that you're not missing anything else. So you make sure it's not infectious. You can do oral steroids and periocular steroids. Because you really don't know, I would not inject intravitreal steroids of any sorts, because unfortunately I've been not personally involved in lawsuits, but expert witnesses for people who've injected steroids in toxoplasmosis eyes, injected into syphilis eyes. And so just be very, very careful with that. You can always stop the drops, oral steroids, and then possible role for vitrectomy. So again, viral retinitis, duh, we all know what this looks like, right? Top panel, you can see very classic acute retinal necrosis with the vitritis and the retinal whitening. In the middle panel, we can see progressive outer retinal necrosis, porn, and again, you can see a clear picture, and again, the retinal whitening. And on the bottom here, you can see the classic pizza pie appearance for CNV, as well as the granular appearance of CNV in a patient that I had with on immunosuppression for kidney transplant. But what happens when it's not so obvious? This is a 26-year-old that was sent in to me for multifocal choroiditis and panuveitis. And if you look all the way temporally, you can see 3 little spots. I said, okay, son, we're going to get you some labs done. He's like, well, I was just in the hospital. Beep, beep, back up the truck. What do you mean you were just in the hospital? I ask you, where have you been, blah, blah, blah. Yeah, I had some labs done there. I was admitted for encephalitis. So I tap and injected him. My fellow at the time was like, I think you're being you're just doing too much. This is what he looked like the next day. And because we were aggressive, we were lucky. His vision returned down to 20/50. He started here at 20/25. So, but again, you have to be suspicious. Same thing here. Again, multifocal choroiditis and panuveitis. We can see the lesions very temporally, and this is what he looked like the next day. This is an HIV patient, and you can see in the superior nasal quadrant some granularity. He had a CD4 count of 4. 1, 2, 3, 4, and walked into our clinic, which was pretty impressive. And Steve Ye has done some really nice research on the uses of autofluorescence in detecting how active these lesions are. And again, granular CNV, we tapped him, CNV was positive, and he was started on Valsite. And lastly here, this was a 56-year-old woman with a pressure of 38, corneal edema. And this little spot in the center, this is sent to me, was my resident sent this to me. And I'm thinking, toxoplasmosis, there's no hemorrhage associated with it. So we tapped her, we sent it for toxo as well as the viral PCR as well. Turns out this was actually CMV. So she met everyone in the hospital. She met hematology, oncology, infectious disease, and rheumatology. And there was nothing that showed she was immunocompromised at all. But again, so what can you do when things are not so obvious? Viral VKH, and obviously toxoplasmosis, these are things where you can have decreased vision with inflammation, but elevated IOPs. And so again, be suspicious. So again, we have here, and Fernando had a great case, that ARN case was great, because we were all thinking lymphoma, and it turns out it was ARN. That just goes to show you have to have high suspicion. So you think I would make it that easy? Of course not. The patient here on the left hand of the slide is progressive outer retinal necrosis secondary to toxoplasmosis. Sent in to me because they weren't responding to Valtrex, even though the PCRs were negative, and they were suspecting, what's going on? And here, pressure was elevated because neovascular glaucoma, and he had Behçet's disease. Toxoplasmosis, the most common form of retinal choroiditis, and you can see these are beautiful classic forms, headlight in the fog, and classic originals with the secondary occurrences right next to the old lesions. So that's what this is, right? Take a moment and look, and you see this nidus, and you see the retinal blood vessel going over it. So it's more choroidal, not retinochoroidal. Yep, turns out this was TB. So again, with TB, it still is a concern as the world gets smaller. There are places out there where there's a lot of multi-drug resistance. And do not forget, it's not just the discrete choroidal lesion. We have here serpiginous. We have here Eales disease, retinal vasculitis secondary to TB, as well as our classic discrete choroidal lesion. And no uveitis talk would be complete without syphilis. And so again, granulomatous versus non-granulomatous, unilateral, bilateral. And here, all cases here, the top panel is a patient sent in for granulomas for possible sarcoid, had syphilis. And if you see syphilis or suspect syphilis, you should also be testing for HIV. Again, here on the lower left-hand side, sent in for possible retinitis pigmentosa, syphilis. And then on the bottom part here, you can see that the left eye was much, much, much more involved than the right eye, syphilis. So in conclusion, I have a high index of suspicion, and this is hard when, you just want to get to the end through your day, and they just keep adding stuff on. But really, if you're not sure, do not inject intravitreal steroids into the eye. You can always stop oral steroids. You can always stop the drops. Rule out infectious causes. And yes, unfortunately, sometimes we have to take a moment or two to find out a little bit of history from the patient. Thank you for your time.
Thank you, Lisa. That was a great overview, and that concludes our session. Thank you to all of our speakers for wonderful presentations, and Barb will make a few announcements.
Yeah. Thank you, Manjo. What a great session and a great morning. It's now time for lunch break. Please head past where you were for the mid-morning break for the lunch, and I need you back by 1:18. We're going to kick it off with the surgical talks. So thank you all.